Welcome back. In this lesson, we're going to actually talk about full arch appliances, and we're actually going to talk about both full arch maxillary appliances and full arch mandibular appliances. And I'll make it simple by basically saying you can pretty much do the same things with both. However, there are some advantages one of them has to the other. And so as we go through this, I'll identify probably the appliance that is easier to wear for the patient, and in some ways maybe easier tolerated by the patient. So when we think about our full coverage appliances, we have just a couple of decisions to make. Besides, do you make it on the upper or do you make it on the lower? So really the two decisions you have to make is, are you going to build the occlusion on the appliance with the condyle seated in a centric relation position, and are you going to create a ramp on the front of the appliance to provide anterior guidance so it separates the posterior teeth? So to walk through that rationale, essentially if we have a healthy joint with the medial pole of the disc in place, and we want to build the appliance to be interference-free in the posterior, then we will build the patient's occlusion with the condyle seated. So that would be the rationale for why we would use a seated joint position, is medial pole of the joint's intact, there's no discomfort on loading, and we want an interference-free appliance. In terms of the ramp for the anterior guidance, typically we build that when in fact we're trying to reduce elevator muscle activity during translational movements left, right, or forward. So seat the condyles in patients with healthy joints, no discomfort on loading. Build a ramp if we're trying to in fact treat somebody and reduce muscle activity during translation. In addition to those two reasons, when we create the appliance or the occlusions in a seated condylar position, we also get a release of the lateral pterygoid muscle by using that seated condylar position. So full coverage appliances, typically very well tolerated by most patients. They're quite safe relatively compared to, for example, the risks of developing the anterior open bite from an anterior bite plane, but you do have to decide, am I going to make it on the maxillary or the mandibular arch? Am I going to make it with the condyle seated or not seated? Am I going to put a ramp on the front of it, or am I going to have it flat plane? So those are essentially the thought processes you go through on your full coverage appliance. Now, if in fact we have a clencher, it is important to realize that full coverage appliances are not going to reduce clenching activity. They do support the joint during clenching, however, but they don't actually reduce clenching activity the way an anterior bite plane potentially can reduce clenching activity. But if we have a patient who we know is going to still clench on an anterior bite plane, the full coverage appliance is safer. Now, what about the full coverage appliance that's flat plane? Typically, the full coverage appliance that's flat plane, again, we have to decide where do we build the occlusion. Is the condyle seated or not seated? And so if we have a healthy joint with a healthy medial pole, then in fact I typically would build the full coverage flat plane appliance with the condyle seated. The flat plane aspect of the appliance is typically used for patients where you want some joint support when the mandible's moving. So reducing the ramp to make it a flat plane, or even going further and making it actually a balanced appliance so there's posterior interferences, that's typically done as a way to support joints when the mandible's moving. So again, your basic decisions are, what's the joint health? And when we talk about joint health, we talk about it in two times. When the condyle's seating, that determines whether we build the occlusion in a seated condylar position or not, and what's the joint health and symptoms when the mandible's moving. If we have joint symptoms when the mandible's moving, we typically would always go flat plane. I would go so far as to say, if you have a traditional full coverage appliance that has a ramp on it and your patient is not doing well with it, one of the first things I would do is actually cut the ramp off completely and make it flat plane. So again, conceptually, we're not getting any decrease in muscle activity in clenching or translation if the posterior teeth are in contact, but what we are getting is joint support. So the flat plane appliance almost becomes, if you want sort of what's the probably safest appliance to put in most patients, so you know the joints are going to be supported, flat plane appliances are pretty safe appliances to use. It's important to recognize that even with a flat plane appliance, you do get posterior disclusion. And the reason is quite simple. When the mandible moves forward, left, or right, the condyle comes down the eminence. And when the condyle comes down the eminence, if your appliance is totally flat, you're going to get posterior disclusion. As soon as that posterior appliance separates, the joint is going to get more load. And so, in fact, flat plane appliances don't provide as much joint support as appliances designed with some form of posterior interference built in them. So when would we not use a seated condylar position? We wouldn't use a seated condylar position either for the flat plane or the appliance with the ramp when we can't seat the joint. So if we have a displaced disc and it's the medial pole so that the joint can't be seated comfortably, then we need to build the appliance with the mandible forward. And the reason being simply that we want to get that condyle forward to relieve pain for the patient. Now let's talk maxillary versus mandibular appliance. I was taught in dental school maxillary appliances. I was taught the classic Michigan appliance, which is a full coverage maxillary appliance, built-in centric relation with a pretty steep ramp on the front of it. Traditionally, that appliance works for what it's intended to do most of the time, if you're talking about protecting teeth from wear, etc. But maxillary appliances are not as easy to wear, especially if a patient wants to wear it during the day. The other issue that comes up concerning maxillary versus mandibular appliances is tongue space. When you create a full coverage appliance, you do take up some space for the tongue. And in the world we live in today with airway and breathing disorder issues, we want to minimize the amount of tongue space we occupy. We really want our patients sleeping with their tongue in the roof of their mouth as they breathe through their nose. So if you do make maxillary appliances, you want to be careful about the bulk of that maxillary appliance. But generally speaking, a lower appliance, this is an example from Todd Davis, a really beautifully made one. A lower appliance is easy to make in terms of adjustment. You can make it flat plane or you can create a ramp for it, but it also doesn't interfere with the tongue being in the palate. Typically today, if I was doing a full coverage appliance, I would lean towards a mandibular appliance and fairly flat, not much of a ramp. And it does allow that patient, as I said, to wear it during the daytime. They can talk with it. It's not as offensive aesthetically as having a maxillary appliance in your mouth. We do have some evidence, but you have to be careful about this research. This comes from Gagnon back in 2004, where they actually took patients who had apnea and they placed maxillary occlusal appliances in to see what happened to their apnea and their snoring. In 40% of the patients, they actually got worse relative to their snoring and their AHI scores. So it is possible in some people with breathing disorders for full coverage maxillary appliances to actually interfere. Now, the problem in the study is that there are some patients that actually probably did get better, from what I understand, because the appliance opens vertical and does some other things. So you can't say that maxillary appliances are always bad in a patient for airway issues, but there's definitely a risk in some of those patients. Relative to the guidance patterns, again, you can make a mandibular appliance flat plane. You can make a mandibular appliance have anterior guidance. It just doesn't have the typical ramp like you think of in a maxillary appliance. And they also can be created literally where they have bilateral balance, where you build in interferences. This is a case of Jeff Rouse's. This patient has a displaced disc, so there's joint symptoms. The disc is anterior, and this is the appliance that was built for that patient. This patient's biting and moving left and right, and you'll see in the molar region there's actually interferences designed into that lower full coverage appliance so that as the patient moves, there's posterior occlusion. Traditionally, you would never think about doing that on teeth, but when you have patients that have joint pain in translation, this is one way to support those joints during translation. So concepts mechanically, the mandibular full arch, seated condylar position, flat plane, that's kind of going to be a universal full coverage appliance for most people. And again, we talked about it in a previous lesson. If the patient's symptoms don't get better, you probably want to not think mechanically. You probably don't want to just think, oh, I need to keep adjusting the bite on it. You might want to, in fact, start assessing the patient's airway. And as I mentioned in that previous lesson, that could mean pulse oximetry. It could mean where you actually have the patient sleep without the appliance for a couple nights, get some baseline oxygen saturation levels, baseline heart rates, put the appliance in, do a couple more nights, and see what the appliance is doing in terms of their airway and breathing. To help you think about how to talk to your patients about full coverage appliances, and again, since you do have online membership, because you're obviously watching this video, let me just play for you one of the patient ed videos about full coverage appliances and specifically also about tooth wear. And again, so just a helpful way so your patient very rapidly understands what the appliance would be like and why you would prescribe it.
For patients experiencing tooth wear due to nighttime grinding and jaw clenching, your doctor may recommend an occlusal appliance, commonly called a night guard or bite splint, to help alleviate the complications associated with the condition. It is not uncommon for tooth wear to be associated with certain airway or breathing conditions, so your doctor may discuss this with you as well. An occlusal appliance is a device that is worn in the mouth overnight and creates a barrier between your upper and lower teeth, eliminating the damage they cause by rubbing against each other. It also promotes improved jaw and bite alignment, which can help address uneven tooth wear. Research has shown that a well-designed hard appliance will help to relax the musculature, reducing wear even when it is not being worn. There are several designs and styles of appliance available to assist with treatment. Your doctor will expertly design your individualized appliance to ensure optimal bite alignment and maximum protection from additional tooth wear. Given the potential for costly dental treatments caused by untreated tooth wear, it is critical to work closely with your doctor to proactively treat the issue before more damage is sustained.
And again, this is something you already have as part of your membership to online. And I would encourage you, these are 60 seconds, 45 seconds typically. They're very helpful for a patient to get it, and you don't even have to be the one that plays it. You can have your assistant or your administrative people, your treatment planning coordinator play the video, but you want a patient to have an understanding of why you're doing what you're doing, why you're suggesting what you're suggesting, and also to have an understanding of what actually it is, what does it do. So let's walk through full coverage appliances. Which ones we use when? Typically, in terms of a full coverage appliance, the full coverage flat plane would be the most common one I would use instead of the classic ramp I was taught. Assuming that the patient has joints that can be seated comfortably, I would build it with the condyle seated. I would also use it to treat or protect teeth from wear or fracture in patients, again, who have healthy joints in terms of condylar seating. As far as not building it in a seated condylar position, that would be for patients whose medial pole of the joint is displaced and the condyle is uncomfortable upon seating. And so basically the decision to seat the condyle or not seat the condyle simply comes down to the health of the joint when you're loading it and where the disc is relative to the head of the condyle. Last little bit about full coverage appliances is vertical dimension. Typically, we need a vertical dimension that allows adequate thickness of plastic in the molar region, probably at least 1.5 millimeters to 2 millimeters. And if we want to do a flat plane appliance, that usually requires the vertical be opened a little bit more than the ones that have a ramp on them. So posterior thickness and anterior steepness, those two things tend to dictate vertical. because I like flat plane appliances or appliances that are fairly shallow, as opposed to the one you see illustrated with the steep ramp. The way I tend to make bite records for appliances is I simply use a Lucia jig. When you use a Lucia jig, effectively, you're making the bite record at the vertical dimension necessary to do a totally flat plane appliance. Then if you want, you could have the laboratory close the vertical slightly if you wanted to produce a little bit of anterior guidance in that appliance. What are the contraindications to full coverage appliances? I think probably one of the biggest ones is if people won't wear them. And so again, that's a pretty thick, bulky maxillary appliance. Not every patient's going to tolerate that. So that's one of the reasons we talk about mandibular appliances actually being better tolerated by the patient. And then obviously, if you make the appliance for somebody in pain and they don't get better, instead of just thinking that you need to adjust the bite, you really do need to start assessing what is it you're missing. Is it in fact a breathing disorder? Is that where the pain's coming from? And your appliance may actually be making it worse, if not better. So some take-home messages for you about full coverage appliances. They're generally very safe and well tolerated. A flat plane appliance built in MIP is almost a universal appliance for patients who have muscle or joint issues combined. Mandibular appliances are typically more comfortable and can be worn during the day. They also have potentially less airway risk. Wearing full coverage appliances 24 hours a day almost guarantees some irreversible occlusal changes. So even though full coverage appliances are safer to wear more than the anterior bite plane, I personally do not want patients wearing them 24 hours a day unless they need it for joint comfort. If it's just a muscle issue we're trying to manage, I really don't want them wearing them 24 hours a day, because over the time you will see occlusal changes. That when they take that appliance out, their bite will not fit anymore. So I hope this makes sense as to the decisions you have to make with a full coverage appliance. Is it upper or lower? Is it in CR or not in CR? Is it got a ramp in the front or is it flat plane? That essentially defines the decisions you need to make. As we move into the next lesson, we're going to move into some of those specialized appliances that I talked about a while back. So look forward to seeing you there.